And I'm going to start with the first lecture on the basics of coronary CT angiography. Cardiovascular disease is currently the leading cause of death in the United States, and it's also a significant economic burden to this country with estimated direct and indirect costs of $351.8 billion in 2003. When you look at the age-adjusted death rate for women, we hear a lot about breast cancer, but in fact the #1 killer of women in this country is cardiovascular disease. And when you look at the overall breakdown of cardiovascular deaths, the majority of them, or 53%, are due to the presence of coronary heart disease. So what we want to do is try and find an easy way to evaluate the coronary arteries non-invasively. And fortunately, with the advances in scanner technology, we can now image the coronary arteries very well with cardiac CT. So what are the basic requirements of cardiac CT imaging? Well, we need to have high temporal resolution in order to minimize motion artifacts, and we achieve that by using fast gantry rotation. We need to have high spatial resolution so that we can depict the coronary anatomy, and we achieve that with thin collimation. We need to have fast continuous coverage so that we can image the whole heart in one comfortable patient breath hold, and we achieve that with the use of multi-slice CT. And we also need to have the ability to synchronize to the heartbeat so we can image during a consistent cardiac phase, and we achieve that using ECG gating. Now, looking at the temporal resolution, what we want to try and do is achieve the same temporal resolution as that of conventional catheterization, which is currently 20 milliseconds. And you can see where we are. The best scanner in terms of temporal resolution is the electron beam CT at 100 milliseconds, and the 64-slice CT currently is at 165 milliseconds. When you look at spatial resolution, again, we want to try and achieve that of conventional catheterization, which is 0.2 millimeters. And you can see, even though the temporal resolution of electron beam CT is very good, it really falls apart in terms of spatial resolution, where it's only 3 millimeters. Currently, the 64-slice CT scanner is 0.4 millimeters. So it's close to conventional catheterization, but not quite as good. One of the hot topics at RSNA was Siemens' announcement that they're going to produce the dual source CT scanner, which has 2 X-ray sources and 2 detectors and allows you to image at both 80 and 140 kV. And this is exciting in terms of coronary CT imaging because when you look at the temporal resolution of the scanner, it's significantly improved compared to the temporal resolution that we're now using on the 64-slice. The dual CT scanner temporal resolution is 83 milliseconds, so it's even closer to conventional catheterization, and the temporal resolution is less than 0.4. And we're hoping to get this scanner in the spring at NYU. So how good is CT in evaluating stenoses? Well, when you look through the literature, it's actually fairly difficult to directly compare studies because different authors have used different criteria for defining what significant stenosis is. But overall, when you look at the literature for the 4-slice CT scanners, you can see that the negative predictive value was very high, between about 97 and 99%. But the positive predictive value was only in the 60% range. And importantly, when you look at the percent of accessible segments, about 30% of them weren't accessible on the 4-slice CT scanner. And when you compare that to the 16 and 64-slice CT scanner, you can see that these scanners maintain the very high negative predictive value. The positive predictive value had significantly improved in the 80% range. And when you look at the percent of accessible segments, that also has significantly improved. And when you look at the published studies to date on the 64-slice CT scanner, the majority of them are not excluding any segments. So when you look at the positive predictive value, it's in the 80% range when you're evaluating all segments. So that is significant improvement, and it's much more reliable in terms of seeing peripheral vessels and small vessels. So there are many advantages to coronary CT angiography, including the fact that it's non-invasive. We get both intra and extraluminal information about the coronary arteries as well as information about the myocardium. The disadvantages we're well aware of, the fact that we need to give the patients radiation, intravenous contrast, and often we need to give the patients beta blockers. What are the contraindications to CT angiography? Obviously, anyone who can't receive intravenous contrast material can't have the study. Patients with significant cardiac arrhythmias and highly calcified coronary arteries and high heart rates are actually relative contraindications, and we'll discuss that in a little bit. In terms of the protocol, it's going to be on your CD. We normally scan from the tracheal bifurcation to the bottom of the heart. If we're imaging the bypass graft patients, we're going to actually scan a little bit higher from the top of the grafts down. This is a calcium score, I'm sorry. So on the calcium score, we image at 3 millimeter thick sections from the tracheal bifurcation to the bottom of the heart. In terms of cutoff for calcium values, people always ask, is there an absolute value that you have above which you won't scan these patients? And we don't have an absolute value. You can see this patient has a calcium score of over 800. What we do is we look at the pictures from the calcium score, we look at the axial images, and we look at the distribution of the calcium and the size of the calcification. In general, when you have long branching calcifications like this, those kinds of calcifications are going to be very difficult to see through, and they often block visualization of the lumen. So a patient like this with a very high calcium score with branching dense calcium like this, we probably would not do. But this is an example of why high calcium scores are a relative contraindication. This is a patient who has a calcium score of 850, so it's very high. But he really didn't want to have catheterization, was having chest pain. So we went ahead and did the coronary CT angiogram. And you can see on the volume rendered image, this patient has a lot of disease in the LAD and in the diagonals. And when you look at the right coronary artery, there's actual occlusion in the mid portion of the right coronary artery. This is all calcium here, calcified plaque. And this is the axial images. Through this patient, you can see the enhancement of the right coronary artery with small calcified plaques. At this point, you see that you lose the enhancement of the right coronary artery, so there's total occlusion in the mid portion of the right coronary artery with reconstitution here distally in the right coronary artery. Okay, so now we have the protocol for the coronary CT angiogram. And these patients, again, we scan from the tracheal bifurcation to the bottom of the heart if we're doing a regular coronary CT angiogram. For bypass patients, we scan from the top of the chest down through the heart because we want to see the takeoff of the grafts also if they have IMA grafts. We use a slice thickness of 0.75 millimeters and a reconstruction interval of 0.5. And we typically, on the Siemens scanner, will reconstruct with a kernel of B30. If we're looking at stents or highly calcified arteries, we often will change the reconstruction kernel to B46. In terms of patient preparation, we don't allow them to drink caffeine the morning of the study, and we have them fasting for 3 hours before the study. We typically will administer between 70 and 100 cc's of Visopaque 320 for our IV contrast. Most patients now are getting about 90 cc's of contrast, and we do use a 40 cc saline chaser in all of our patients. Our injection rates are generally at this point about 5 cc's a second, and we preferentially inject using a 20 gauge IV in the right antecubital fossa. We are very aggressive in terms of beta blocking our patients. We try and achieve a heart rate in the mid-50s if we can. And I found that the oral metoprolol really is the best way to start. If these patients come in with a heart rate of about 65 or greater, we'll generally start with oral beta blocker because I think it works better to start with than the IV. And once we give them the oral beta blocker, we have them wait for about 45 minutes before we do the scan. Once the 45 minutes are up, we put them on the table, and if we need to, we'll then give them additional IV metoprolol in 5 milligram aliquots, and we'll give 4 maximum in that. In terms of beta blocking, you have to do it with caution in patients who have asthma, aortic stenosis, AV block, or severe left ventricular dysfunction. And then before we do the study, after we've already set our scanning parameters, we do give these patients a sublingual nitroglycerin to help distend the arteries. Why do we use a saline chaser? Well, there are many benefits, including the fact that you get greater arterial enhancement. It helps to maintain a tight contrast bolus, and it helps to reduce streak artifact from contrast in the right side of the heart. It also allows us to reduce the amount of contrast that we need to use by about 15 to 20%, which in turn helps to decrease contrast-induced nephropathy and also to decrease costs. And this is what can happen if you don't clear the contrast material out of the right side of the heart. You can see the dense contrast here in the right atrium, and this is causing streak artifact over the right coronary artery. So this is in fact what we like to try and achieve, where we have all the contrast or most of the contrast in the left side of the heart for the coronary arteries. Now obviously if you're going to be looking for a mass in the right side of the heart, you're going to change this injection protocol, but for coronary artery imaging, this is the enhancement that we like to achieve. So there are many factors that affect arterial enhancement, including contrast factors such as the total amount of contrast administered, the injection rate, the concentration of the contrast, the viscosity of the contrast, and whether or not you're using a saline chaser. There are also many patient factors, including their weight and their cardiac output, and then their scanning techniques. So what should become readily apparent is that you can't use an empiric scan delay to image these patients. So there are two ways that you can identify what your scan delay should be. You can either use a test bolus, where you do a series of low-dose monitoring scans in the ascending aorta. For the test bolus, you inject about 10 cc's of contrast material at whatever injection rate you're going to be using for the study, along with your saline chaser. You generate this enhancement curve, and then you use the peak time to determine your scan delay time. What we prefer at NYU is the automatic bolus tracking technique, where you do a series of low-dose monitoring scans in the ascending aorta. You watch the enhancement of the ascending aorta, and you pre-program when the scanner initiation will be. So you tell the scanner to trigger at a certain threshold, and once the enhancement curve reaches that threshold, the scan initiation triggers. Now, why do we like this method better? Well, I like it because, first of all, you can watch the contrast material go in, so you know that the patient's not extravasating. You also have a visual monitor of what's happening, so that if you set a threshold level and you see that it doesn't look like your patient's going to reach that threshold, you can automatically tell the technologist to initiate scan triggering. The other thing you always want to do is you always want to tell the technologist to isocenter the heart for the scan. And once you have the scan data, you want to reconstruct with a small field of view, and that'll help to improve your resolution. Now, there are two types of ECG triggering that you can use, prospective or retrospective. Prospective triggering is step-and-shoot sequential scanning, where you have a predefined acquisition point and you tell the scanner to trigger at that predefined point. The advantages are that it's a lower radiation dose and it's fast, but there are many disadvantages, including the fact that you need a regular heart rate because you're dealing with a predefined acquisition point. It's sequential mode, so it's single transaxial slices, not volumetric scanning, and there's less Z resolution. So what can happen is if your patient has an irregular heartbeat, you're going to have misregistration because you're dealing with a predefined acquisition point. So most people are using retrospective ECG gating to do dedicated coronary CT angiography. And the advantages are that it's a spiral mode, so you have volumetric data acquisition through the entire cardiac cycle. And then data from specific parts of the cardiac cycle can be retrospectively referenced to the ECG signal for image reconstruction. Therefore, you get a true match of the data to the ECG trace. It's isotropic Z resolution, and it's less dependent on regular heart rhythm than prospective ECG gating. The disadvantage is that it is a higher radiation dose. So if you're going to use retrospective reconstructions, which as I said most people use, you can do it either as a fraction of the RR interval, and if you're only going to do a couple of reconstructions, the ones I would recommend would be the 30%, 55%, and 70%. Excuse me. We also reconstruct every 10% throughout the cardiac cycle so that we can do 4D imaging, and I'll show you some of those images a little bit later on. The other thing you can do, rather than doing a percentage of the RR interval, is to reconstruct an absolute time point either prior to or following the R wave. And we typically will also reconstruct at -350 milliseconds, -400, and -450 milliseconds on the Siemens scanner. The other thing you can do is preview slices to try and figure out which reconstruction interval is best for looking at the coronary arteries. And often you need to look at more than one reconstruction because the right and left coronary arteries move separately. So what you can do is do a preview series where you can reconstruct using different percentages, and that allows you to look and see which of the percentages is best for the artery that you're trying to evaluate. And in this case, you can see that the 40% reconstruction is actually the best one for looking at the right coronary artery, and then you can go back and reconstruct the entire data set at 40%. The other thing you can do is edit the data set if you have problems with abnormal heartbeats during the acquisition. This is a patient who had an irregular rhythm, and you can see here that on our first acquisition, our first reconstruction, we had this artificial duplication artifact in the distal right coronary artery. So what we did was delete some of the irregular heartbeats. We changed our reconstruction to a percent reconstruction, and by doing that, you can see now that we have a beautiful non-motiony picture of the distal right coronary artery. In terms of trying to reduce radiation dose, one of the things you can do is use ECG-controlled dose modulation. And what that does is it keeps the nominal tube output during diastole when we're going to image the coronary arteries most commonly, and then it decreases the dose to about 20% during systole. And using ECG dose modulation, you can achieve dose reductions of about 30 to 50% depending on the patient's heart rate. Which brings me to the question, well, what is the CT radiation dose that we're giving these patients? And just so you know, the natural background radiation dose is about 2 to 5 millisieverts per annum in this country. For a routine multi-slice chest CT, most patients are getting between 4 and 6 millisieverts. And for a diagnostic coronary catheterization, it really varies depending on who's doing the catheterization. Most of the time, it's going to be on the order of about 7 to 10 millisieverts, although in the literature it says 3 to 10 millisieverts. So the question is, what are we giving with CT? And for a calcium score, overall men are getting about 3 millisieverts and women about 4 millisieverts. On the 16-slice CT scanner, overall men are getting about 12 and women about 16 without use of ECG pulsing. If you use ECG pulsing, you can reduce this to about 1.1 millisieverts for calcium score and about 4 millisieverts overall for the 16-slice dedicated coronary angiogram. And then the question is, what are these patients getting using the 64-slice scanner? And these are the numbers that I had gotten directly from Siemens using an effective MAS of 850. With ECG pulsing, most men are getting on the order of about 10 millisieverts and women about 14 millisieverts. And that's expected to decrease to about half with the use of the dual scanner, the new dual scanner. This is in your CD that you're going to be getting. This is the nomenclature for numbering the segments of the coronary arteries. And I have it so that you'll be familiar with it. I don't want to spend a lot of time on this because you will have it to review. But basically, in the right coronary artery, proximal is segment 1, the mid is segment 2, and the distal is segment 3, with the posterior descending artery segment 4 and the posterolateral artery labeled as segment 16. In the left side, the left main is segment 5. The proximal LAD is segment 6. The LAD beyond the takeoff of the first septal perforator is segment 7, and the LAD beyond the takeoff of the second septal perforator is segment 8. The first diagonal artery is segment 9, and the second diagonal artery segment 10, and the proximal circumflex is segment 11. The first obtuse marginal artery is segment 12. The intervening segment of the circumflex is segment 13, and the second obtuse marginal is segment 14, with the distal circumflex being labeled as segment 15. So how do we go about evaluating our data sets? Well, we usually initially start by scrolling through the axial data. So this is the right coronary artery. You can see the takeoffs of the acute marginal arteries. You can follow the right coronary artery distally. Where it branches, you can see the posterior descending artery coming down to the apex, and the posterolateral segment coming across laterally. Coming back up again, the acute marginal branch is there. And then we look at the left side. We're going to have the left main, which bifurcates into the LAD and circumflex. Diagonal branches coming off laterally here. Septal perforators coming off medially. Follow the LAD all the way down to the apex. and we can see it coming back up. Again, the diagonals over here, septal perforators medially. And the circumflex coming down here, obtuse marginals coming off laterally from the circumflex. Here's an obtuse marginal. So we'll start by scrolling through the axial data. For our patients and the referring physicians, we'll often create MIP images of each of the coronary arteries along with volume rendered images, because one of the first questions our patients always ask is, am I going to get the colored pictures of my heart? So we always do that. And it's an easy way for the referring physicians to present the results to their patients. You can also survey the coronary arteries using MIP imaging, but be very careful. You don't really want to make diagnoses using the MIPs because they can hide small stenoses. And then volume renders, again, are very good for looking at the anatomy, for looking at the position of the arteries, especially if you have complex anatomy like anomalies or bypass grafts. And you can, again, cut off overlying structures with the volume render technique so that you can nicely see here a ramus branch, the circumflex artery with the obtuse marginals coming off, and the LAD with the multiple diagonal arteries. The curved reconstructions are also another way that you can evaluate the coronary arteries. It allows you to lay out the length of the coronary arteries, and I find them most useful for looking at bypass grafts and for looking at the touchdown points of the grafts to look for graft patency. So I just want to go through some cases now. This is a 42-year-old man who had an elevated cholesterol, occasional chest pain, and a family history of heart disease. And when we did his calcium score, you can see that the score was actually very low. It was 1. So this patient would be considered to be extremely low risk for cardiovascular disease based on that calcium score. But when we did the dedicated coronary CT angiogram, what we could see was this eccentric non-calcified plaque here in the proximal LAD. You can see it here on the volume rendered image. Once we see a segment of plaque, we tend to look in biorthogonal projections so that we can look down the lumen of the vessel, the so-called IVUS view, because it mimics the view that they get with intravascular ultrasound. And on the IVUS view, you can see this is the enhancing lumen of the vessel. You can see this large eccentric non-calcified plaque here along the proximal LAD. And you can also look at the movie. It helps to appreciate this is a normal segment. This is where the plaque is coming in here, narrowing the proximal LAD. And this is the IVUS images from this patient who went on and had both a cath and an IVUS. Excuse me, and this confirms the large amount of eccentric plaque along the proximal LAD. This is another patient, a 60-year-old man who had occasional chest pain. And what we can see here is that when you look at the right coronary artery, there's this large eccentric non-calcified plaque along with calcified plaque in the mid-right coronary artery. You can see that here, eccentric non-calcified and calcified plaque. This is the volume rendered image, which again shows the narrowing in the mid-right coronary artery compared to the more normal proximal segment and distal segment of the right coronary artery. And this is the comparison view from the cath, showing again the nice correlation between the cath and the volume rendered image. And this patient did go on and have stent placed through this. This is a 41-year-old asymptomatic man who had a normal stress thallium test and a very low calcium score of about 7. And when we did his coronary CT angiogram, we could see that there was eccentric non-calcified plaque along the proximal LAD. And here again, this lobulated eccentric plaque, a little tiny calcified focus right there. And this is a magnified view of it, again showing the luminal narrowing here in the proximal LAD compared to the more normal segment distal to that. This is a volume rendered image, again showing the narrowing here in the proximal LAD. And this is the catheterization image, again showing excuse me, the very nice correlation, again showing the narrowing here in the proximal LAD. And this is this patient's IVUS, again showing the eccentric plaque along the proximal LAD. Coronary CT angiography is an excellent way to look at bypass grafts. This is a patient who has a patent lima graft, anastomose to the distal LAD. And in addition to the patent graft, we can see this nubbin of what was left of an occluded saphenous graft. Another patient here with multiple bypass grafts. This patient had a Rima graft to the right coronary artery, had a Lima graft anastomose to the distal LAD, and had a saphenous graft to the obtuse marginal artery distally. And in addition, you can see again an occluded saphenous graft below the patent saphenous graft. And doing volume rendered images allows you to really rotate the anatomy. Looking at the touchdown points allows you to get a good overall survey to see the anatomy, and then you can go on and evaluate the data using your multiplanar reconstructions or curved reconstructions to evaluate the anastomotic point. But I think the volume rendered images are a really good way to start to look at the bypass grafts. CT angiography has been a little controversial in terms of stent imaging. The small stents we really do have a problem with. It seems that we do better with the bigger stents, and it does vary depending on the type of stent and the position of the stent. It does help when you increase your reconstruction kernel to a sharper kernel to a B46 kernel. And this is a patient who has a stent in the LAD. This is just to show you that on the volume rendered images, you can use cut planes to look through the anatomy, cut away overlying anatomy. Again, you can see the stent here in the proximal LAD. This is what we want to see. This is a stent that we did several months ago on the 64-slice scanner. And you can see how easily we can see all the way through the stent, really beautiful images longitudinally and on the cross-sectional view through the stent. So this is what we want to try and achieve in every patient. And this is the volume rendered image again showing the stent in the proximal LAD. This was a case I did a couple weeks ago. This is a 50-year-old cardiovascular surgeon who came in with chest pain. He had had bypass grafts placed. You can see there's a saphenous graft to the right coronary artery, a Lima graft to the LAD. You can see with the curved reconstruction allows you to see the anastomosis of the Lima graft very well. This patient also had a stent in his LAD, and when we looked at the stent, you can see that there's really no contrast material that we can see through this segment of the stent, and that's because the stent was occluded. You can see it just looks very black there. And then we went on and looked at the left ventricle. We could see this very large thrombus sitting here in the left ventricle. So coronary CT angiography is a very good way to look at the ventricle and to look at the coronary arteries and bypass grafts. Coronary angiography is also a really excellent way to look for coronary artery anomalies. This is a 47-year-old woman who came in with atypical chest pain, and what we can see is the left coronary artery is coming off the right sinus. This is the right coronary artery here. So it's coming off the right sinus. It's actually passing posteriorly between the aorta and the left atrium as it crosses to the left side of the heart. Now, heart rate, as I said, is a relative contraindication, and this is a patient who had come in, had a very high heart rate, but we couldn't beta block him because he had a very low cardiac output. So we actually scanned him with a heart rate of 94 beats per minute. But what we can see is this patient had chest pain, and we can see that there's an anomalous left coronary artery, which is coming off the right coronary sinus. This is the right coronary artery, this is the left, passing between the pulmonary artery and the aorta to reach the left side of the heart. And this is a so-called malignant configuration. The problem is that the artery can get squeezed as it's passing between the artery, the pulmonary artery and the aorta. And this is one of the causes of sudden death. So this patient went on and did have surgical correction of this anomaly. So not beautiful images, but certainly diagnostic images, and that was what was important in this case. This is another patient we had several weeks ago, a 44-year-old who had chest pain. She had had a prior stent placed in her LAD. And when we imaged her, what we could see is she also had an anomaly. She had an anomalous right coronary artery, which was coming off the left coronary sinus, and again, crossing between the pulmonary artery and the aorta. So here's the left coronary artery, here's the right coronary artery coming off the left sinus, crossing between these two. So again, a malignant configuration. This is the images of her scrolling through LAD, and this is that right. Let's look at that again. This is the stent coming off the left coronary sinus, passing to the right side of the heart. This gives new meaning to the phrase, cross my heart and hope to die. So this is another anomaly here. This patient has an LAD which actually comes off posterior to the circumflex and crosses over the circumflex to get to the anterior aspect of the left heart. And this is a 12-year-old who has Kawasaki's disease that we imaged a couple of months ago. They were looking for aneurysms of her coronary arteries, and what we could see was this mild fusiform dilatation of the proximal aspect of her right coronary artery. This is the curved reconstruction, again showing the mild fusiform dilatation of the proximal aspect, and the rest of her coronaries were good. Now, I talked about 4D CT. We can do that when we reconstruct throughout the cardiac cycle. And what that does is allows us to look at the heart in different imaging planes. It allows us to look at myocardial motion, myocardial contractility, and also look at the valves. And Barbara Srichai is going to be talking about this more in the next talk. But just to show you in terms of imaging other things besides the coronary arteries, it's always important to look at the rest of the heart when you're doing coronary artery imaging. So this patient had a large left ventricular aneurysm. You can see the aneurysm down here at the apex. You can see the abnormal contractility of the apex of the heart, this dyskinesis down here at the bottom of the heart. So also, whenever we do coronary imaging, we do 4D CT. You can also look at function using 4D CT. And we look at both myocardial contractility and look at the valves. And this is a normal aortic valve. You can see the valve leaflets opening and nicely coapting. And contrast that to this patient where you can see calcification along the aortic valve. This patient had a functional bicuspid valve, and you can see the restricted motion here of the valve leaflets. Let's see if I can move on to the next slide. And this is a short axis view of the aortic valve. Again, a patient with normal valve motion. You can see the valve leaflets nicely opening and completely coapting when they close. And contrast that to this patient who has aortic insufficiency, where you can see centrally the valve leaflets aren't coapting normally. You can see this little hole for the where the regurgitant flow is occurring. But this is a movie just to show that you also want to look at the thickness of the myocardium. This patient, well, you can't see, had proximal septal hypertrophy, so had eccentric thickening. So always look at the thickness of the myocardium also. So in conclusion, I hope I've shown you that coronary CT angiography is excellent for depicting the coronary anatomy, and it's proving to be a really accurate technique for evaluation of coronary artery disease. It's great for looking at anomalies and bypass grafts. We hope it will be getting better